Good morning, good evening, good afternoon, wherever you are. Welcome to another intensivecareathome.com and intensivecarehotline.com live stream. Today I want to cover premature baby to adult lifelong ventilation, tracheostomy and independence at home. This is what we are covering today. We'll be going approximately for an hour here to cover this topic, but if I am finished earlier, leaves you room to ask questions to today's topic or to anything related to intensive care at home or intensive care hotline. So again, hello everyone and welcome. I'm so glad you're joining me today for this incredibly important conversation about lifelong ventilation care from premature babies all the way through to independent adults living at home with tracheostomy and ventilation. So if you're new here, please hit the subscribe button, the like button, the notification bell, and share this video with anyone that will benefit from it. My name is Patrick Hutzel, and I'm the host of this show today. I am a critical care nurse by background, having worked in critical care nursing for over 25 years in 3 different countries where I've covered, intensive care nursing in ICU, pediatric ICU, as well as I've been a nurse manager for over 5 years in ICU. And I've been working with intensive care at home, in Germany a while ago, and I've set it up successfully in Australia since 2012. So, this covers obviously my area of expertise today. And I've been doing videos here on my YouTube channel and at intensivecareathome.com and intensivecarehotline.com since 2012. So I've got a large library of topics that I'm covering on my YouTube channel when it comes to intensive care at home, and helping families in intensive care. So we provide evidence-based guidance for families in intensive care, navigating intensive care, both in hospital and with intensive care at home. And if this content helps you today, give us a thumbs up so more families can find this information. Today, we're covering a journey that many families don't even know is possible. We're talking about premature babies with bronchopulmonary dysplasia, children growing up with tracheostomies, teenagers navigating school with ventilation, tracheostomy, and adults living independently at home with 24/7 CCRN support. So, who should watch this topic today? Parents of premature babies in neonatal and pediatric ICU, families with ventilated children with or without tracheostomy, adults requiring long-term ventilation, again with or without tracheostomy, healthcare professionals supporting these patients in hospitals, but also at home, and anyone navigating the transition from hospital to home ventilation. And drop a comment right now and tell me where you're watching from and what brings you here today. Are you currently in hospital, planning discharge, already at home with ventilation? Are you a healthcare professional watching this and curious about the topic? Let me know. So before we dive in, let me give you a quick roadmap for today. Roughly for the first 30 minutes, we'll cover the hospital journey from neonatal ICU through pediatric intensive care, understanding bronchopulmonary dysplasia, tracheostomy decisions, non-invasive ventilation options such as BiPAP, CPAP, and the challenges of long-term hospital stays. In the second part of the conversation, we'll focus on home care, evidence-based mechanical home ventilation guidelines with intensive care at home and 24/7 critical care nurses at home, community access, school inclusions, employment relationships, and truly independent living with quality of life that surpasses what's possible in an ICU setting. And it's also surpassing what health professionals in ICU envision what's possible for these people. They might often focus on, it's quote unquote in the best interest of your family member just to stop life support and letting them die because they won't have any quote unquote quality of life. And I can assure you nothing could be further from the truth. There is quality of life on the other end with intensive care at home. So throughout this live stream, I want you to drop your questions in the comments. I'll be answering them as we go along and during our questions and answers segment at the end if we have time. I also want to welcome any viewers that are watching this on replay, because I know we're getting a lot of views on replay as well. Also want to welcome anyone, whether you're watching on YouTube, on Rumble, on LinkedIn, whichever platform you are using. And remember, if you need personalized guidance for your specific situation, head over to intensivecarehotline.com, where we provide one-on-one consulting for families in intensive care, neonatal ICU, pediatric ICU, for those ready to explore home ventilation options. And you're ready for that, go to intensivecareathome.com, because we have comprehensive information about our 24-hour ICU and critical care nurses at home, including pediatrics and neonatal home care services. All right. Let's dive right in. The beginning is neonatal ICU for bronchopulmonary dysplasia. Let's start at the very beginning of this journey, the neonatal intensive care unit. So premature birth and respiratory challenges when a baby is born prematurely, especially before 28 weeks gestation, their lungs are simply not developed enough to breathe independently. These tiny fighters often develop a condition called bronchopulmonary dysplasia, or BPD. So what is bronchopulmonary dysplasia, or BPD? BPD is chronic lung disease that develops when a premature baby's lungs are changed from mechanical ventilation and oxygen therapy. The very treatments that save their lives can cause inflammation and scarring in their developing lungs. These babies may need mechanical ventilation through an endotracheal tube, high oxygen concentrations, positive pressure support, sometimes for weeks or even months. The critical decision point: when does temporary become long-term? So here's where many families find themselves in limbo. After weeks in neonatal ICU or NICU, doctors and nurses start discussing whether this baby will need long-term ventilation support. This is terrifying for parents, because suddenly you're not talking about getting through a crisis. You're talking about a lifestyle change. Let's talk about non-invasive ventilation in neonates. Many babies with BPD can be managed with non-invasive ventilation. CPAP, continuous positive airway pressure, provides constant pressure to keep airways and alveoli open. BiPAP, also known as bi-level positive airway pressure, provides 2 levels of pressure, higher when inhaling, lower when exhaling. These babies wear tiny masks or nasal prongs and can often avoid tracheostomy if their condition improves over time. So, when is a tracheostomy considered? A tracheostomy becomes the discussion when a baby has been intubated for 6 to 8 weeks or longer. Multiple extubation attempts have failed. Or if there are upper airway abnormalities, then long-term ventilation is clearly needed. And quality of life would improve with a tracheostomy versus prolonged intubation, simply because when someone requires prolonged intubation versus a tracheostomy, they need sedation, opiates with devastating side effects, such as muscle wastage, potentially brain damage, and the issue is that there's often delays in getting, kids to mobilize and so forth. So let's also look here at the reality in hospitals. Here's what many families don't realize. Staying in the hospital long-term is not the only option. In fact, prolonged hospitalization comes with significant risks. Number 1, infection exposure. Hospital-acquired infections are a major concern. Developmental delays. Babies need normal sensory stimulation, family bonding, natural daylight. Family separation. Parents can't be there 24/7. Siblings can't visit regularly. And of course, limited quality of life, hospital routines, noise, lack of normal experiences. And that The lack of quality of life includes the patient, the child, the neonate, but also includes the family, of course. You don't have any quality of life in a neonatal or in a pediatric ICU if you are watching this. And this is exactly why our services at intensivecareathome.com exists. We provide 24/7 ICU, pediatric ICU, and neonatal ICU support at home so babies and children can leave the ICU and grow up at home with their families. So, and I can see that one of your first questions would be who's going to pay for it? Well, let me say that we'll address the cost and funding in the second half. Keep those questions coming, but just to plant the seed, keep in mind an ICU bed or a neonatal ICU bed or pediatric ICU bed costs upwards from $5,000–6,000 a day. I can assure you that intensive care at home is much more cost effective and you get the same level of care in a home care setting. But we'll cover that in more detail in the second half of this presentation. But let me be clear about something very crucial here. If your baby or your loved one needs ventilation and tracheostomy care, and they're in neonatal or pediatric ICU and they want to go home, they must have 24-hour ICU, pediatric ICU, neonatal ICU nursing support, whether in hospital or at home. It's not optional. This is so specialized, life-sustaining care that it requires critical care nursing experience 24/7. Anything less than that will lead to children dying. And I will have something to say about that later as well, that if the right support is not provided, children will die at home. So let's talk about next what happens as these babies grow. So childhood with tracheostomy and ventilation. Your baby has survived the neonatal ICU period. Now what? Let's talk about growing up with the tracheostomy and ventilation needs. The toddler years, mobility with medical complexity. Toddlers are meant to explore, crawl and walk and get into everything. Having a tracheostomy and ventilation needs doesn't stop this, but it requires 24/7 intensive care nursing, specialized care at home. In a neonatal or pediatric ICU, children are confined to beds, attached to wall units, surrounded by medical equipment, often in dark rooms with no natural daylight, and therefore developmental milestones are delayed because mobility and a natural family environment are restricted. So at home, with 24-hour critical care nurses, here's what's different. Portable ventilators allow freedom of movement. Children can play in different rooms, go outside, experience normal environments. Speech therapy can happen in natural settings. Siblings can interact normally. Parents can parent, not just hover as visitors in an ICU. Right? And for school-age children, education can happen with ventilation. This is where the quality of life difference becomes dramatic. Let's compare. In ICU, in hospitals, children receive limited bedside education, miss social development, have no peer interaction, experience institutional life during their formative years. Let's compare that to intensive care at home with 24-hour critical care nursing support as is evidence-based. Children can attend school with their nurse, with the intensive care at home nurse, participate in activities, make friends, have birthday parties, experience childhood, play with their peers, and so forth. And at intensivecareathome.com, all of our ventilated and tracheostomy clients have full community access, whether they're adults or children. We don't just keep them alive, we help them live. So let's look at evidence-based home mechanical ventilation guidelines that you can find on our website at intensivecareathome.com. Our approach follows the evidence-based mechanical home ventilation guidelines, again, that you can find on our website at intensivecareathome.com. These evidence-based protocols that are a result out of over 25 years intensive care at home nursing in Germany, and also a result out of intensive care at home nursing in Australia since 2012. Those guidelines ensure proper ventilation, setting and monitoring, emergency preparedness and backup systems, infection prevention strategies, developmental support integration, regular equipment maintenance, communication with medical teams as appropriate, and more importantly, 24/7 intensive care nursing at home to provide intensive care at home so kids don't have to stay in an ICU in a hospital long term. So let's also look at tracheostomy care in growing children. As children grow, their tracheostomy care evolves. Tube sizes change with growth. Speaking valves may be introduced. Some children can be capped during waking hours. Independence skills are gradually taught. Children learn to participate in their own care. Let's also look here at the psychological aspect, which is huge, because there's identity beyond medical and nursing needs. Here's something hospital ICUs and pediatric ICUs often miss. Children need to develop identity beyond being a patient. With 24/7 critical care nurses at home, children experience normal family dynamics, household routines, community access and participation, friend and family relationships, hobby development, self-advocacy skills. One of our clients recently told me that her daughter said, "I'm not the sick kid at school. I'm just," and I use a fake name here, "I'm just Sophie who has a nurse." That's the difference between institutional care and evidence-based home care that's holistic and patient and family friendly. Let's now talk about types of ventilation in childhood. Let's clarify the different approaches. Number one, invasive ventilation with a tracheostomy, which often means 24/7 ventilator dependence, or it can be part-time ventilation, daytime versus nighttime, or naps, or during naps, portable ventilators for community access. All of that requires 24-hour intensive care nurses. Let's look at another alternative, which is non-invasive ventilation, such as BiPAP, CPAP. Might be nocturnal support only, but it could be daytime and nighttime. It depends all on the condition. Could be through a mask or through a nasal interface. Because it's a ventilator, it still requires skilled monitoring, especially in children, with 24/7 critical care nursing essential for reliability and safety, preventing complications such as pneumothorax, for example. Both options are absolutely viable at home with proper 24/7 critical care nursing support. And let's also be clear about the toll on families in situations like that. When a child is hospitalized long-term, parents become visitors in their child's life. Siblings feel neglected. Marriages strain under the pressure. Financial burden from travel, accommodation, lost work. Guilt and grief become constant companion. Let's compare that to 24/7 critical care nurses at home. Family life can approach normal. Parents can be parents, not bedside caregivers. Siblings grow up together. Home routines provide stability. Professional critical care nurses handle medical care with families, focusing on family. This doesn't mean it's easy. It means it's possible. And that's what intensivecareathome.com provides. Possibilities. And if you're watching this and think, "I wish I knew this was an option," please share this video. There are families right now being told their only option is institutionalized care, or they're being told the only option is withdrawal of treatment because their child won't have any quote unquote quality of life, and it's in their best interest to die. That's a whole lot of nonsense and needs to be challenged any day of the week because we can provide the level of care that's needed at home. And Hospitals saying that institutionalized care or end of life are the only options is simply not true. So, all right, let's talk about the teenage years, which brings their own unique challenges. So, adolescent challenges and transition planning. The teenage years are complicated for every family. Now add ventilators, tracheostomies, and medical complexities in the mix. Teenagers want independence, privacy, and to fit in with their peers. How does this work with 24/7 intensive care nursing support at home? Let's look at the hospital scenario. Teenagers in pediatric or adult ICU experience complete loss of privacy and dignity, no peer interaction, developmental regression, depression and anxiety, educational disruption, social isolation during critical identity formation years. This is not sustainable and it's not necessary. Let's again look at the bright side, which is home care with CCRNs. Teenagers can have their own room with a nurse stationed nearby, attend high school with nurse support, participate in adapted sports and activities, develop romantic relationships, learn independence skills gradually, advocate for themselves in medical settings, make age-appropriate decisions about their care. And then let's look at the transition from pediatric to adult care. This is a critical junction that's often mishandled in hospital settings. Around age 18, patients transition from pediatric to adult care systems, and this can be disruptive or even dangerous without proper planning. At intensivecarehome.com, we specialize in this transition. Continuity of CCRN care regardless of age. Coordinated handoff between pediatric and adult specialists. Maintained relationships and routines. Youth involvement in transition planning. Family support through the process. And also independence goals and self-management. By adolescence, ventilated individuals should be developing self-management skills such as understanding their diagnosis and needs, recognizing when something isn't right, communicating with their care team, making decisions about their care, and planning for their future. This happens naturally at home with supportive CCRNs who encourage autonomy. It doesn't happen in institutionalized settings where patients are passive recipients of care. But let's also address the elephant in the room, which is mental health considerations. Depression and anxiety are common in chronically ill adolescents, especially those who've spent their lives in medical settings. The evidence is clear. Quality of life and mental health outcomes are significantly better for ventilated individuals living at home with community access compared to those living in institutionalized settings. Our clients at intensivecarehome.com don't just survive, they develop friendships, fall in love, graduate high school, make plans for their future. This is what's possible with proper support. Let's also look at education and career planning. With 24/7 CCRN support at home, teenagers can complete high school education, participate in vocational training, attend college with nurse support, develop career interests, gain work experience, plan for financial independence. None of this is possible from a hospital bed. Now let's look at the cost question. I know many of you are thinking this must be impossibly expensive. Let me give you perspective. Hospital and ICU costs for long-term ventilation. ICU bed $5,000, $6,000, up to $10,000 per bed day, depending on location. No developmental services, no community access, no quality of life, ongoing risk of hospital-acquired infections, and health professionals in hospital that look after you with no community view, with no community access view. It's a very limited mindset because we know that treatment can easily be moved into home care and doesn't need to stay in a hospital. Again, let's compare that with 24/7 critical care registered nurses, significantly lower daily cost, normal development and life experience, community participation, family preserved, better health outcome, better psychological outcomes, better psychosocial outcomes. Most insurance plans and government programs cover home ventilation care when medically necessary. The question isn't can we afford home care, is can we afford not to provide home care with 24-hour intensive care nurses? Because if you're not, children have died at home. And I can give you 5 examples, but I can tell you that in the earlier days when we were having more funding challenges than we were having now, 2 of our clients passed away during the daytime. 2 of them were children because the NDIS wasn't funding daytime CCRNs. We warned them that those children would pass away, and they did. Not even a couple of weeks after we announced to the NDIS saying we need to fund 24-hour CCRNs, children are at risk of dying, and that's exactly what they did. They died because support worker, general registered nurses without ICU experience or parents could not manage medical emergencies. I hope the NDIS sleeps well at night. I hope that the NDIS support coordinators that were involved in those cases sleep well at night because they didn't do the advocacy. So if you're dealing with funding challenges, with intensivecareathome.com and also intensivecarehotline.com, we provide extensive consultation services to help families navigate coverage and advocacy. We also provide level 2 and level 3 NDI support coordination, and our NDI support coordinators know exactly what to do when it comes to funding challenges. We're also providing WorkSafe and TAC case management. Now, looking ahead into adulthood for the patients that we're talking about, as adolescents approach legal adulthood, new questions arise. Where will they live? How will they support themselves? Can they live independently? What about relationships and possibly parenting? The answer to all of these depends entirely on one thing: whether they've been institutionalized or empowered. Now, we believe we empower our clients at intensivecareathome.com. In the next segment, we're going to talk about adult life with ventilation, employment, independent living, relationships, and how 24/7 CCRN home care makes all of this possible. But before we move on, I want to address a few comments I'm seeing. And, common questions we're getting quite frequently is, can we select our nurses? Can we help you create a team? And we say, absolutely, yes. We always help our clients to select our team members so that you feel comfortable having the right nurses in your home, right? And another question we get quite frequently: how do you get the funding? Once again, we cover that in the second part of this presentation. Funding has never been an issue. We would not exist if funding was an issue. Intensive care at home would not exist in its current form if funding was an issue. Now, just give me 20 seconds. Okay, so let's now move on. Home ventilation, the evidence and the reality. So welcome to the second half of our YouTube live stream here. Today we're talking about premature baby to adult, lifelong ventilation, tracheostomy and independence at home. If you're just joining us, we're discussing this topic today. The first 30 minutes covered the hospital journey, the ICU journey. Now we're focusing exclusively on home care, how it works, why it's superior, and what makes it possible. Let's start with the evidence-based foundation. At intensivecareathome.com, we don't just offer home care, we provide evidence-based intensive care at home, mechanical home ventilation guidelines following established clinical guidelines. You can review these on our website at intensivecareathome.com. These mechanical home ventilation guidelines address patient selection criteria for home ventilation, ventilator types and settings for home use, monitoring and safety protocols, emergency preparedness, ICU nurses 24 hours a day as the minimum standard. Those nurses need to have a minimum of 2 years ICU nursing experience, ideally with a critical care nursing qualification. Around 50 to 75% of our critical care nurses have completed a postgraduate critical care nursing qualification, which is why I'm confidently saying there's no other service provider in Australia that brings a higher level of skill into the community. As a matter of fact, we're employing hundreds of years of intensive care nursing experience combined. No other service provider can match that. And the other reason why people are working for us is we are the only third-party accredited intensive care at home nursing service in Australia in 2025. No other service has the intellectual property, the teams, the staff, the policies, the procedures to make intensive care at home possible. And also, equipment maintenance standards is obviously very important, and quality of life outcomes. So why 24/7 critical care nurses, intensive care nurses are non-negotiable? And let me be absolutely clear, home ventilation with tracheostomy or complex non-invasive ventilation requires 24/7 critical care registered nurse support. It's not a luxury. It's a medical necessity to keep clients alive. The same is applicable if clients have a tracheostomy without ventilation. Because here is what CCRNs provide. Immediate recognition of ventilator malfunction, immediate recognition of tracheostomy issues, emergency response capability, tracheostomy care monitoring, respiratory assessment, expertise, medication management, complex care coordination, family support and education about the environment that we work in, proactive problem prevention. Some families are told they can manage with family caregivers or non-specialized nurses or even support workers. Let me be clear, this is inadequate and life-saving. It's actually a death sentence from my experience. Ventilated patients deserve critical care nursing expertise 24/7 a day in their home. Once again, I can give numerous examples where funding bodies have failed adults and children, and because of that, they died in the hands of support workers, in the hands of registered nurses without ICU experience, in the hands of family members, parents, spouses, siblings, and the list goes on. And it is absolutely preventable, right? So if you are being told that support workers can do this, well, ask yourself, why are there no support workers in ICU doing this? Now you have your answer. So let's look at the home care environment. Home care environment is designed for living. Let's compare environments once again. ICU environment, fluorescent lighting 24/7, constant noise and interruptions, no privacy, restricted visiting hours, institutional food and schedules, limited personal belongings, no control over environments, isolation from community, no consistency in staff, people come and go. Let's look at home care with 24/7 intensive care nurses with intensive care at home, natural lighting and circadian rhythms, normal household sounds and routines, personal space and privacy, family always present, home cooked meals and personal preferences, personal belongings and comfort items, control and choice in daily life, integrated community access, and a regular team with people you know, like, and trust. Because we don't send you staff that you don't like and trust, right? That may not happen from day one, but over time, we can mold teams to your liking. Now, as you know, physical environments impacts health outcomes. Studies show better sleep, lower infection rates, improved psychological well-being, enhanced rehabilitation in home settings compared to institutionalized care, not even mentioning family cohesiveness, marriages surviving and people staying together, as opposed to marriages not surviving when there are medically complex children in the household or living in an institution. Now, let's talk about portable ventilation technology. Modern home ventilators are sophisticated yet portable. Portable units on wheelchairs or mobility devices, battery backup for community outings, wireless monitoring capabilities, user-friendly interfaces, reliable and durable for home use. This technology enables our clients at intensivecareathome.com to leave their homes regularly, something impossible in hospital settings where patients can really only leave their bed space if they're going for x-rays, ultrasound, CT scans, MRI scans, and so forth. Also, let's talk about infection prevention at home. Here's a critical point. Infection risk is lower at home than in hospital. Hospital-acquired infections are a leading cause of complications in ventilated patients. At home, exposure to multi-drug resistant organism is decreased. Environmental control is better. Cross-contamination from other patients is eliminated. Personalized infection prevention protocols can be implemented. Our CCRNs maintain strict infection prevention protocols while allowing normal life to continue. Now, I also know families worry, what if something goes wrong at home? Well, it's not any different to if something goes wrong in a hospital, because you've got a 24-hour intensive care nurse model, which includes backup ventilators on site, battery backup power systems. We recommend that you have a generator, emergency action plans, direct communication with physicians and doctors, rapid response protocols, hospital transfer coordination when needed, regular emergency training for our staff. But CCRNs are trained to handle emergencies. In fact, response times are at home with an on-site CCRN, generally speaking, are much faster than in hospital setting where nurses sometimes are too busy. Now, let's also look at the care team approach. Home ventilation involves a coordinated team, 24/7 CCRNs providing direct care, pulmonologists managing respiratory needs, or ICU doctors managing respiratory needs, or respiratory physician managing the respiratory needs, primary care physicians or GPs for overall health, respiratory physiotherapists for chest physio, movement, and so forth, physical and occupational therapists, speech therapists, especially for tracheostomy patients, dietitians for nutritional optimization, mental health professionals when needed, and care coordination with intensivecareathome.com. This team meets the patient where they live, not the other way around. Now, let's look at family training and partnership. While CCRNs provide 24/7 care, we also empower families with knowledge, basic tracheostomy care, recognizing warning signs, emergency response, ventilator basics, communication techniques, care participation at your comfort level, never eliminating the 24-hour critical care nurse. Families might want to become partners in care, but certainly not overburdened caregivers, putting the cohesiveness of the family at risk by doing so. So let's also now talk about cost effectiveness and insurance coverage. The financial argument for home care is compelling. ICU care and hospital care costs hundreds of thousands of, if not millions, annually with no quality of life benefits. Again, ICU beds, $5,000, $6,000, up to $10,000 per bed day, depending on location. Home care with 24/7 CCRNs, significantly lower cost with dramatically better outcomes. Most insurance plans, including Medicare, private health insurance, NDIS, TAC, iCare, NIISQ, and so forth, depending on your situation, are happily paying for intensive care at home as opposed to ICU beds. So the key is proper documentation and advocacy, something we help with at Intensive Care at Home and intensivecarehotline.com. And again, like I said, especially if you're watching this and you're in Australia with NDIS, we provide level 2 and level 3 NDIS support coordination, and we can help you with funding regardless, even if you have your own NDIS support coordinator already who is stuck in the process. We can help you. Our NDIS support coordinators are very experienced. Again, otherwise we wouldn't exist. So there's a question coming in, someone asking, have you had those kids? And yeah, absolutely. We've helped wean some of those kids off ventilation and tracheostomy at home. So it doesn't have to be lifelong ventilation, but what is important, in order to reach those milestones, you need to go home from ICU, because, children develop so much better at home. So we've supported kids to be weaned off the ventilator and the tracheostomy, and I know those kids are thriving now. We've also helped similar kids with overnight ventilation, tracheostomy care, and those were the kids that actually passed away, where the NDIS has been grossly negligent, and also NDIS support coordinators have been grossly negligent. And those kids are no longer with us, and it is extremely sad that these things happen. But, everybody has learned from it, and that's why I'm here, to help you understand that 24-hour intensive care nurses is not negotiable. It's a life-saving necessity, and you should not go home without 24-hour nurses. The hospital will support you as well, because if you refuse to go home without 24-hour nurses, they will keep you there, and that will strengthen your argument. Now, let's also look at community access and quality of life. Let's talk about what that really means and why it matters. Quality of life and community participation. All of our clients at intensivecareathome.com have full community access. This isn't just possible, it's the standard we set. So what does community access mean? Community access means leaving home regularly for activities, attending school, work, day programs, shopping, dining, entertainment, movies, sport events, whatever floats your boat. Social gatherings and events, medical appointments outside the home, travel for family visits or vacations even, participation in community activities. We've gone traveling with our clients. We've put clients on planes, on trains, on vans. We've gone traveling with them for a whole week or longer, or for weekends. It's all possible. Because with portable ventilation, portable equipment, and 24-hour intensive care nurses support, the world opens up again. Compare that to a long-term ICU bed. Also, let's talk again about school inclusion with CCRN support. Children and teenagers with ventilation needs can attend school with their ICU nurse. The ICU nurse accompanies student to classes, manages medical needs discreetly, coordinates with school staff, enables full participation in curriculum, supports social integration, handles emergencies if they arise, but more importantly, they prevent medical emergencies if they arise, before they arise. Way more important. I want you to imagine the difference: a child learning alongside peers versus a child isolated in a hospital bed receiving time-limited bedside instruction. The developmental outcomes aren't even comparable. Now, we also want to talk about employment opportunities. Yes, adult with ventilation can work with 24/7 CCRN support. Workplace accommodation is arranged, or they can work from home. CCRN provides on-site support, of course, 24/7. Reasonable modifications are implemented, productivity and capability are demonstrated, financial independence becomes possible, and our clients can have a purpose, which is so important. We have supported clients in various employment settings, from office work to home care, people working from home. The limiting factor is not the ventilation. It's access to proper support, 24/7 intensive care nurses, which we provide. Now, let's also talk about social life and relationships. Ventilated individuals want the same things everyone wants: friendships, romantic relationships, social activities, community belongings. In hospital, these are impossible. At home with community access, they're normal. Our clients date, marry, maintain friendships, participate in hobbies, join clubs and organizations, and live socially connected lives. Let's also look at the psychological impact of community participation. Research consistently shows that community integration dramatically improves mental health outcomes, life satisfaction, sense of purpose, self-esteem, resilience, overall well-being, Isolation, even in the best hospitals, causes psychological harm. Connection heals. Adaptive recreation and hobbies with creativity and CCRN support. Almost any interest can be adapted: arts and crafts, music and performance, adaptive sports, gaming and technology, nature and outdoor activities, cultural events, spiritual practices. In our environment, life isn't just about surviving, it's about thriving and enjoying what makes us human. Travel and family visits, family events, holidays, vacations, these don't stop because someone needs ventilation. With proper planning and 24/7 CCRN support, family visits are possible, holidays can be celebrated at home or away, vacations can be arranged, extended travel is feasible, like I just mentioned. We've coordinated care for clients traveling interstate and even internationally. It requires planning, but it's absolutely possible. And let me be clear, what we're talking about today is dignity and choice and control. Perhaps the most important aspect of home care with community access is this, the autonomy and dignity and choice and control. In hospital and in ICU, you follow schedules, eat what's provided, see who visits during hours the hospital wants to have, and live by institutional rules. At home, you make choices: when to wake up, what to wear, what to eat, what to spend, who to spend time with, how to spend your day, what activities to pursue, how to live your life. This autonomy is fundamental to human dignity and well-being. Compare that to ICU quality of life versus quality of life at home with community access and your family around. And let me paint this picture even more clearly. Long-term ICU is confined to a bed or a chair in one room, shared space with other patients, no community participation, limited family access, institutional environment, no personal choice or control, social isolation, developmental stagnation, depression and anxiety is common, existence without living, and a very, very high risk for getting an infection. And again, let's talk about home care with 24-hour intensive care nurses and community access with intensive care at home, full home environment access, private personal space, regular community participation, family integrated into daily life, familiar surroundings and routines, personal autonomy and choices, social connections and relationships, continued development and growth, better mental health outcomes, actually living life. The choice is crystal clear. The question is whether families know this choice exists. That's why we're here today. That's why intensivecareathome.com exists, to make this life possible for ventilated individuals and their families. And now let's talk about transitioning to adult independence and what that really looks like. Adult independence and future planning. Because this is really powerful. Adults with lifelong ventilation needs living independently with 24-hour support. It means when a young person with ventilation needs approaches adulthood, new possibilities emerge: independence or supported living arrangements, higher education and career development, financial and relationship autonomy and choices, life decisions about their own future. This transition from parental home to independence is challenging for any young adult. For ventilated individuals, it requires careful planning and robust support, but it's absolutely achievable. Several living arrangements work with 24/7 CCRN support: independent apartment or home, individuals living in their own space. 24/7 CCRNs provide rotating shifts, of course. Individual maintains autonomy and privacy, manages their own household with support. But it can also happen in supported living communities, small group setting with peers, balance of independence and community adapted environments. That works for other clients. Let's also look at continued family home with independence. Adult lives with family by choice. 24/7 CCRN provides the care allowing family to be family. gradual independence with safety net, transitioning at individual's pace. All models require 24/7 intensive care nurse coverage for safety and medical management. The difference is the setting and level of autonomy. Let's look at higher education with ventilation. College attendance is possible with proper planning, campus accessibility assessment, accommodation coordination, CCRN scheduling for classes and campus life, emergency protocols with campus health services, housing arrangements, dorm or off campus. We've supported clients through undergraduate and graduate programs. Education doesn't stop because you need ventilation or a tracheostomy. Adult ventilated individuals can pursue meaningful careers, workplace accessibility and accommodation, CCRN support during working hours and after hours, technology and enabling remote work options, self-employment and entrepreneurship, even part-time or flexible arrangements. And financial independence through work provides more than income. It provides purpose, identity, social connections, and self-determination. Let's address what many people wonder but hesitate to ask. Yes, ventilated individuals have romantic relationships, get married, and some even have families. With 24/7 CCRN support that respects privacy and boundaries, dating is possible. Intimate relationships develop, marriages occur. Some individuals become parents. Our CCRNs are professionals who provide medical care while respecting personal boundaries. Private time is private time. The key is communication, planning, and working with our CCRNs who understand the whole person, not just the medical and nursing needs. Is parenting with ventilation possible? And it deserves special mention. Some of our clients are parents with adaptations and support. Parenting skills can be developed, childcare adaptations can be implemented. CCRNs support medical needs while parent provides parental care. Is it complex? Yes. Is it possible? Absolutely yes. Adults with lifelong ventilation needs require ongoing attention to respiratory health optimization, musculoskeletal care and positioning, nutrition and weight management, mental health support, preventive health screening, aging-related health changes, equipment updates as needs evolve. 24/7 CCRN care ensures proactive health management rather than reactive crisis management. Adult independence requires financial planning, disability benefits and eligibility, health insurance navigation, NDIS navigation, supplemental insurance considerations, employment income management, housing costs and assistance programs, long-term financial security, and estate planning and future care. Again, at intensivecarehotline.com and intensivecareathome.com, we help families navigate these complex systems through our consultation service. Also, individuals who have been ventilated since childhood or early adulthood will age with their medical needs. Planning for aging includes anticipating age-related health changes, adapting equipment and care as needed, planning for eventual increased support needs, advanced care planning and directive completion, ongoing quality of life maintenance. The goal isn't just longevity, it's living well throughout the lifespan. So again, some of the success stories that I can share with specific clients, but privacy obviously, will not get me to share names. But what I can tell you is that we have clients who have been weaned off the ventilator and the tracheostomy at home that were premature babies, and they're thriving now, right? But also, even if a client needs lifelong ventilation, whether it's with BiPAP, CPAP, or whether it's with a tracheostomy, they're going on to live their lives. They go to school, they can work, they might go to college, they might go to university, they travel regularly, they maintain employment, they live independently, they have rich social lives, they can advocate for disability rights and even mentor others with similar conditions and live fulfilling, purposeful, and self-determined lives. None of this happens from a hospital bed. All of this happens through evidence-based home care with 24/7 intensive care nursing support, full community access with intensive care at home. And also, let's break down barriers, because the biggest barriers to independence aren't medical, they're systemic and attitudinal. Low expectations from hospitals, insurance and funding challenges, lack of awareness about options, housing accessibility issues, employment discrimination, social stigma and misconceptions. Our work at intensivecareathome.com isn't just providing care, it's breaking down these barriers and providing what's possible. And let's just move into our final section, which is taking action and next steps. We've covered an incredible amount of information today, from premature babies in NICU to independent adults living their lives with ventilation support. Let's talk about practical next steps for different situations. If you're currently in hospital, whether you're in neonatal ICU, pediatric ICU, adult ICU with long-term ventilation or tracheostomy needs, here's what you need to do. Get a discharge planning today. Involve your medical team specifically about home ventilation options. Request social work and case management to be involved. Document everything and obviously have us involved in the conversation. And you can contact us either at intensivecarehotline.com or intensivecareathome.com. We review your specific situation. We provide expert guidance on feasibility, and we help you advocate with your medical team. And we connect you with our team here so that we can take the next steps. We also help you research your insurance coverage, NDIS, TAC, private health insurance, departments of health, and so forth, because we have experience where the funding is coming from. Once again, otherwise we would not exist. Now, before we wrap this up, are there any questions so far? If not, I also want to talk about, type them in the chat pad anyway. If not, I also want to quickly talk about if you're at home already, but you're struggling. Maybe you're at home already with inadequate support, family caregiver burnout, or non-specialized care. If you are at home with non-specialized care in particular, you are at risk of dying. I am sad to say that, but I've seen reality. I know what reality looks like. If you're at home already, you're better off going back to a hospital until you have the right funding in place. But if you're at home without 24-hour intensive care nursing, you are at risk of dying. Especially if you're bouncing back into hospital, but even if you're not bouncing back into hospital, you're still at risk of dying. You have a decline in quality of life, social isolation, fear and anxieties about emergencies. We can change all of that. You can upgrade to 24-hour intensive care nursing. Contact us at intensivecareathome.com. Transition to critical care expertise, improve safety and outcomes, get more funding, allow family members to be families, not caregivers, enable community participation, and we optimize your care plan. And lastly, if you're a health professional, if you're ICU doctor, ICU nurse, respiratory physiotherapist, etc., OT or case manager, go to intensivecareathome.com. We can help you empty your ICU bed at a much faster pace, safely, right? And you can partner with us to help us help you free up your ICU beds much faster. You won't pay for it. So I'm going to wrap this up for today. Thank you so much for watching. Go and check out intensivecareathome.com. Go and check out intensivecarehotline.com. If you need further conversations, send us an email to either info@intensivecareathome.com or to support@intensivecarehotline.com. We will help you, and we will make the transition possible for you from ICU to home, even if you're living in a rural or a remote area. And if doctors in ICU say it's not possible, well, I can tell you, our doctors will tell you that it is possible. I can tell you it's possible, and our nurses will tell you it's possible. Thank you for watching. Share the video with your friends and families. Like, comment, subscribe, and I'll talk to you again during the week and next week again with another live stream. Take care for now. Now, with intensive care at home, we are currently sending our ICU and critical care nurses into the home 24 hours a day. We are providing the following: home care services for ventilated adults and children with tracheostomies with critical care nurses 24 hours a day. A genuine alternative to a long-term stay in intensive care or long-term acute care, tracheostomy care for clients without ventilation, home care services for patients on non-invasive ventilation such as home BiPAP, home CPAP, home TPN, which is also known as IV nutrition, home IV potassium and home IV magnesium infusions, IV fluids, and IV antibiotics. We are providing central line management, PICC line management, Hickman's line management, as well as port management at home. We're providing nasogastric tube and PEG tube management at home, the use of cough assist machines for our clients for airway clearance at home, palliative care services at home, as well as ventilator weaning at home. We're also sending our critical care nurses into the home for emergency department bypass services. We have done so successfully as part of the Western Sydney Local Area Health District, their In Touch program, saving approximately $2,000 per patient that we keep at home instead of them going to an emergency department. That also means we're in a position to cut the cost of an intensive care bed by around 50%. An intensive care bed costs between $5,000 to $6,000 per bed day. Our service costs between $2,500 to $3,000 per bed day, and we're freeing up the most sought after bed in the hospital, which is the ICU bed. Most importantly, we're improving the quality of life for patients and their families, which is a win-win situation for all stakeholders. Of course, quality of life is much improved surrounded by families and by a team of dedicated intensive care nurses in the home care setting instead of in an intensive care unit. With intensive care at home, we are currently operating all around Australia in all major capital cities, as well as in all regional and rural areas. We work with NDIS clients all around Australia, TAC and WorkSafe in Victoria, Department of Veteran Affairs all around Australia. Our clients and we as a service provider have also received funding through public hospitals, private health funds, as well as departments of health. We are having policies and procedures for intensive care at home nursing, and we've built all the intellectual property for intensive care at home since 2012. No other provider in Australia has created more intellectual property when it comes to intensive care at home nursing than we have. This puts us in a position to employ hundreds of years of critical care nursing experience combined in the community. No other service provider in 2025 employs a higher skill level in the community than we do, which enables us to look after the highest acuity adults and children in the community in Australia safely. So if you're at home already and if you're watching this, or you're stuck in an ICU long-term, or if you're going to hospital and ED all the time and you realize that you don't have the right level of support at home, or if you are stuck in an ICU, I'll give you a real-world example today how we can help you. One of our first clients when we first got started in 2012 was a client who was at home initially on a ventilator with a tracheostomy with a support worker model 24/7. Of course, support workers are not equipped to look after a client at home on a ventilator with a tracheostomy. That is dangerous and it's simply negligent. Having support workers looking after a client at home on a ventilator with a tracheostomy is like flying the airplane with the cabin crew instead of the pilot, because anyone on a ventilator with a tracheostomy is at very high risk of medical emergencies 24/7, or even at high risk of dying if they don't have a team of dedicated critical care nurses looking after them 24/7 at home. This is actually evidence-based and is documented in our mechanical home ventilation guidelines that you can find on our website at intensivecarehome.com. Think about it. In an intensive care unit in a hospital, you wouldn't have support workers looking after your critically ill loved one or after any critically ill patient on a ventilator with a tracheostomy. So why would anyone in their right mind do that in a home care environment in the community? So this client at the time found out about us eventually, and the ICU that he was basically living in also knew about us and eventually reached out to us. And we were proving our concept with this client very fast. When we worked with this particular client, we sent him critical care nurses 24 hours a day, and he never ever went back into ICU ever again as long as we were working with this client. We can do the same for you if you're not safe at home and help you with keeping you at home predictably. Otherwise, we would not be in business. Again, the same is applicable for those stuck in an ICU, similar to this case study that I've just given you. Or if you're going back to ED all the time, please reach out to us. We can help you with taking you through the right steps, including how to get funding with different funding bodies. This is also why we are providing NDIS support coordination. We have a team of NDIS support coordinators, and they have a wealth of knowledge. I've done an interview with Amanda Richards, one of our NDIS support coordinators, and I'll put a link to an interview with Amanda in the written version of this blog. We're also providing TAC case management and WorkSafe Case Management in Victoria with Lucy McCodder. If you're an NDIS support coordinator or a case manager from another organization watching this and you're looking for nursing care for your participants, please reach out to us as well. If you need more evidence for nursing care, we are also writing NDIS nursing assessments with legal nurse, critical care consulting nurses. If you are a critical care nurse and you're looking for a career change and you want to join a very progressive, dynamic and high-performing team of critical care nurses in the community, we're employing hundreds of years of critical care nursing experience combined. You can join this high-performing team if you are a critical care nurse. If you are looking for a career change as a critical care nurse, we're currently hiring for jobs for critical care nurses in Melbourne, Sydney, Brisbane, in Albury, Wodonga, in Bendigo, in Geelong, in Warragul, in Victoria. If you have worked in critical care nursing for a minimum of 2 years, pediatric ICU, ED, and you have already completed a postgraduate critical care nursing qualification, we will be delighted hearing from you. I do have a disclaimer though, because we are offering a tailor-made solution for our clients, which includes regular staff. Our clients also do want the same staff coming over and over again because they are so vulnerable and so special. That's why we need regular staff. So if you're looking for agency work where you can come and go, this will not be the right fit for you. We are looking for consistency and our clients are looking for consistency. So please only apply with us if you can give us regular and consistent availabilities for shifts and you're really keen on building solid relationships with us and with our clients. If you're an intensive care specialist or an ED specialist, we also want to hear from you. We're currently expanding our medical team as well. We can also help you eliminate your bed blocks in your ICU and in your ED for your long-term patients or for your regularly readmitting patients with our critical care nursing team at home. We're here to help you take the pressure off your ICU and ED beds, and in most cases, you won't even pay for it. Even if you do pay for it, it is so much more cost-effective than what you're paying for in ICU and ED, and you get the same level of care. And if you're a hospital executive watching this and you have bed blocks in your ICU, ED, and respiratory wards, or for home TPN, please reach out to us as well. We can help you eliminate your bed blocks very fast. If you're in the US and in the UK, and you're watching this and you need help, we want to hear from you as well. We can help you there privately with one-on-one consulting and with hiring nurses privately. Once again, our website is intensivecareathome.com. Call us on one of the numbers on the top of our website or simply send us an email to info@intensivecareathome.com. And if you like my videos, subscribe to my YouTube channel for regular updates for families with intensive care at home and intensive care. Click the like button, click the notification bell, share this video with your friends and families, and comment below what you want to see next or what questions and insights you have from this video. Thank you so much for watching. This is Patrick Hutzel from intensivecareathome.com, and I will talk to you in a few days. Take care for now.